So this is the first lecture burst to cover chapter 14, which is psychological disorders, and as well chapter 15, which is treatment or therapy for psychological disorders. So normally in class I would be covering simultaneously the two chapters. Like each time I talk about a disorder, I would talk about therapy after. So that's kind of typically how I do it. So this set of lecture slides is going to be good for this week as well as for next week. So any of these lecture bursts that you listen to here in week 13 will also be in the week 14 tab. So typically we start out just kind of doing an overview of disorders and then therapies. So I'm going to just skip a couple of slides in. I'm going to start by defining psychological disorders. What makes a psychological disorder is something that is a deviant behavior in one culture. So whatever's deviant within our own culture. Okay, because sometimes some things that are deviant here may not be deviant in another culture. So it needs to be culture specific. And it would probably be something that wouldn't be acceptable, not just something that's taboo, but something that's not acceptable, maybe something that might lead to arrest. The deviant behavior needs to accompany a certain amount of distress that it causes for the person, usually putting either the person or others at harm. And the behavior is dysfunctional, so it doesn't work for the person, for their life, for the lives of the others around them that love them. So those are kind of like the three key things. It needs to be deviant, distressful, and dysfunctional. To study the abnormal, the best way is to study the normal. So we tend to label what's abnormal once we understand what's normal within our society. According to the World Health Organization, there's 450 million people suffering from psychological disorders. And it's when we know more about a disorder that we're able to better attend to it and understand it, starting to use medical models to review the physical causes behind some disorders, as we're going to be talking about. Today, what we use to classify psychological disorders is called the DSM-5, revised now. There's a revision. And this is the Diagnostic and Statistical Manual that categorizes all mental disorders, put out by the American Psychiatric Association. Describes over 250 different psychological disorders in 20 different categories, like kind of subcategories. So the goals of the DSM are to, number one, determine how prevalent a disorder is, like how many people have it, how widespread is it, at what rate does it occur in the population, what symptoms categorize the disorder, and then organizing those disorders into quote unquote like categories, which really helps us to see how various disorders are related to one another. A lot of times there's overlap, so someone might have anxiety, but they might also have depression. And so that helps us to understand comorbid mental health issues, different disorders that go along with one another. The disorders outlined in the DSM are reliable, therefore diagnosis or diagnoses by different professionals would be similar, right? So you would see a similar diagnosis by one clinician and another if using the DSM. It helps keep that continuity and reliability. Although some criticize the DSM for putting any kind of behavior within the compass of psychiatry, people fear labels and stigmatizing, but we know that it helps us to understand disorders. Some say that the DSM has casted too wide of a net and brings almost any kind of behavior within the compass of psychiatry. But labels create, some preconceptions, and those preconceptions can bias some of our interpretations and some of our memories. And one result of that is that we could make an erroneous or misleading diagnosis. And sometimes that diagnosis can be self-confirming. So the person or the clinician might search for evidence in the client's life history or hospital behavior that might be consistent with that diagnosis. Okay, so while the DSM is helpful and needed and necessary, the downside is it can also lead to a stigmatization or labeling that could be hurtful to people, but also useful. So it's sort of like a double-edged sword. To diagnose a mental disorder, there's a video that's actually in your text reading, so you're going to want to watch that. Talks about the definitions of a mental disorder, what's abnormal behavior, what risk factors are, and how they relate to developing a mental disorder, and how patients can get the most out of therapy. That's all in your book. So as you're reading, I want you guys to watch that video. These are the individuals that typically work in a mental health care setting. Everyone from a psychiatrist who has a medical degree. This is a doctor, right? So a medical doctor who also has specialized training in brain and behavior. So that the psychiatry end, to a psychiatric nurse, also medical training. These two can prescribe medications. Clinical psychologist is not a medical doctor, but holds a doctoral degree and has extensive training in psychiatry and the mind and behavior. And then kind of like the next tier would be your counseling psychologists, counselors, psychiatric social workers, kind of on the front lines, working one-on-one with clients out in outpatient settings or in a hospital clinical setting. And then your clinical social workers. So make sure you're familiar with the different roles that these folks play. Who does diagnosing, who does patient care, treatment, that sort of thing. We're going to start with talking about anxiety disorders in this lecture burst. We'll see how far we get before the next one. But anxiety disorders are classified by feelings of excessive apprehension and anxiety and include all of these categories. So these are subcategories of anxiety disorders. We have generalized anxiety disorder, or GAD. It's about 3.1% of the population of anxiety disorders. Panic disorder, it's about 2.7. Phobias, which are about, all types is probably 18.1. Specific phobias, 8.7. And we have OCD, obsessive compulsive disorder, that's 1%. And PTSD, which you've heard a lot about, is probably one of the more popular, but still only 3.5%. This is trauma-related disorders. When we're talking about generalized anxiety disorder, this is anxiety that's not specific to any one thing. It's kind of just a general anxiousness, but the symptoms could be somatic, emotional, cognitive, and behavioral. So somatic is the body. That's what's going on with the body when you're experiencing anxiety. So a feeling of tenseness in the muscles, fast-paced breathing, increased adrenaline, maybe sweating more, so increased perspiration, a dry mouth because you're not salivating as much, dilated pupils, increased heart rate. So all of those are the somatic things that actually the sympathetic nervous system is very responsive, overly responsive to the environment and causes those physical symptoms. Emotionally, the person might be feeling a sense of dread, restlessness, irritability, terror, fear. Cognitively, what's going through their head, what they're thinking is they're anticipating harm. They have a lot of hypervigilance, like they scare easily. Someone who's hypervigilant is like every little noise or every little thing sets them off or bothers them. Can be very worried, ruminating, so dwelling, thinking over and over and over about the same thing. fear of losing control, fear of dying, sense of unreality. And then behaviorally, what they do, what you can see observationally in the person's behavior, is they try to escape or avoid the thing that's maybe causing the fear. They could act out in aggression. They could freeze and not act at all. We might see a decreased appetite. So those would all be signs or symptoms that are behavioral. People with maladaptive anxiety really have unrealistic concerns and fears. They're not fears that are normal. What they're anxious about can't hurt them, or is very unlikely that it would hurt them. For example, people have a panic attack and they might fear that they will suddenly keel over and die, although it's really unlikely that anyone's going to keel over and die from a panic attack. So the amount of fear experienced is really out of proportion to the harm that the threat that they're feeling would even cause. Also, with anxiety, people's concern is persistent, even when the threat passes. And so they have a lot of anticipatory anxiety about the future, things that haven't even happened yet, like what's to come, worry about the future. With panic disorder specifically, this is characterized by minutes-long episodes of intense dread. So some of those feelings I talked about, the terror, the chest pains, heart palpitations, maybe feeling numbness or tingling sensations, trembling or shaking. They might even have nausea or upset stomach. And anxiety is a component of both disorders, generalized anxiety disorder and then panic disorder. It occurs more in the panic disorder, making people avoid situations that cause it. So these panic attacks occur more with panic disorder. So someone who is labeled with panic disorder, they're experiencing those panic attacks very often. But we know that a lot of times phobias set people off. And there's specific things people are afraid of that they fear. Here's just a few that I've put here. Your book talks about a lot more. If you want, you can Google it. There's, I think, over 300 types of phobias, maybe even more now. But you know, phobias can be anything. Just even fearing being judged or embarrassed in front of other people could be considered a phobia. So people will do anything to avoid the thing that causes the fear. And it's usually an irrational fear. Here's some other types here. And so it's something that's really, it's an object that's disrupting their behavior. Now, OCD is sort of an offshoot of anxiety. It falls in the anxiety category. It's characterized by two things primarily: unwanted thoughts, so the persistence of unwanted thoughts, which are referred to as obsessions, and then the urge to do something about those thoughts. So the person engages in sort of ritualistic behaviors or compulsions to try to rid themselves of the worry of the unwanted thoughts that are causing distress. So two components, obsessions and compulsions. Common obsessions that we see are, and these again are the repetitive thoughts that the person's having, might be concern with dirt or germs, toxins. Could be something bad happening to them, like a fear, worry, or dread of an accident happening or a death or an illness. Also overly concerned with symmetry or order or exactness or perfection. And then the compulsions that people do to have to rid themselves of those obsessive thoughts would be excessive hand washing, bathing, toothbrushing would be the one that they would use with the dirt or the germ obsession. Repeating rituals over and over, going in and out of a door, turning on and off a light switch, getting up and down from a chair. And this would be, you know, somebody thinking something bad's going to happen to them. And if I just do these rituals, it might prevent that. Of course, it never does. And then checking doors, locks, appliances, brakes, checking things over and over until finally satisfied that they're okay, but until it happens again and they have to start the process all over. So we're going to stop there and I'll pick up on the next lecture burst.